Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. Today we're going to talk about a subject that everyone has experience with, and that is pain. Unfortunately, pain can be very disabling at times, and for people they need more options as what they can do for that chronic pain syndromes that they experience. Our guest today is Dr. Sean Lee. Dr. Lee is a board-certified anesthesiologist and fellowship trained in pain management. Dr. Lee, welcome to the show.
Thank you for having me.
Tell me a little bit about your background.
Well, I started out my career as an anesthesiologist.
Okay.
From there, I developed an interest in doing interventions, being trained in working on the epidural space in the spine. It was a direct short shot in treating folks with a little bit more chronic types of pain. So I decided to do a fellowship which involves additional training in treating specific patients with chronic pain and difficult pain cases in terms of interventions.
Great. And where is your practice located now?
Our main office is in Shrewsbury, but we have various satellite offices both in Middlesex, Essex, Monmouth, as well as in Ocean counties.
Great. Now, a patient comes to you, typically they're suffering from pain, obviously. And when you see them for the first time, what is a typical workup like, and what are some of the common things that you see?
I think I see patients in various stages of their chronic pain. Sometimes it would be a fairly straightforward sciatica case, as we know it, where there's a nerve being pinched either by a disc or some type of spinal pathology. Or patients have gone through the gamut and gone through the gauntlet and have tried various things and nothing's worked for them, and we try to first figure out where their pain is and take it from there. It usually involves an initial consultation, a thorough history, as well as a physical exam, followed by the necessary diagnostic imaging to figure out what are the next options and steps. And I do this, with cooperation from my other colleagues, including yourself, in terms of forming a team of specialists that can help them in their pain.
Great. So typically these people have tried more conservative options, and now they need more interventions or things that are more invasive in terms of reducing their pain. When you have somebody that has this chronic pain, how do you handle the things, and it's often in the public, the medication issues and the dependencies? What do you do in that regard? Because I'm assuming medication sometimes is an option to treat pain.
Correct. It's often a multifaceted approach, and you have to understand pain is not just a physical entity. Our specialty societies identify pain as both emotional and physical. So a lot of folks come to me with there's an emotional aspect as well. Okay. So I feel like sometimes I'm part psychiatrist, I'm part anesthesiologist, and part interventionalist, and in part just being their friend. I think once we diagnose what the problem is, we generally start with conservative treatment options. That may include physical therapy, that may include medications. I know the opioid prescription medications has been in the news quite a bit. There is a concerning abuse issue. However, that doesn't mean opioids are not an option, but we just have to make sure that they're the appropriate option.
Okay. And so you're talking mainly for the spine there. I mean, obviously you treat other joints that are painful.
Correct.
What are some of the typical interventions for people with, say, joint pain, and they come to you for treatment?
So I would say more than 50% of my patient population do have spinal-related pain. There's a lot of joints in the spine, but that doesn't mean there isn't other causes of pain. And peripheral joints is a common one. Knee joints, shoulder, hips. Those are all things that we treat, and I would say most of them are due to arthropathies, arthritis, related pain, or folks who've had surgery and still have pain. Options anywhere from therapy, aggressive range of motion therapy, anti-inflammatories, and then there are some injectables in addition to just steroids that we can place that allow the joints to have a little bit more lubrication and cushioning to provide them with pain relief.
Now, sometimes the steroids get a bad rap. We're talking a different type of steroid to help reduce inflammation in a joint. Is that correct?
Well, steroids, I would say, still is the best anti-inflammatory that we have. In limited doses, they're perfectly safe. However, if we use them too often, they do have side effects, just like any other medication. In addition to steroids, there are some non-steroid-based materials or medications we can inject. Specifically, I'm assuming that you're referring to some of the hyaluronic acid-based materials. Patients come in and show me articles about these gel that are somehow it's been advertised as purified from chickens' combs, roosters' combs. I'm not sure if they do that anymore, but the premise behind that is it's a very thick lubricant that allows the joint to have increased motion and less friction.
Yeah, so people sometimes they'll ask me about it as well. Is this going to replace my cartilage in my knee? Is it going to prevent me from getting a knee replacement? What is a typical patient that you use that on? Is it somebody that's early on, early arthritis, or somebody more advanced?
I think it'd be used in a variety of cases where some folks are a little bit too early to have a knee replaced and want to delay or see if they can get by with less invasive measures. And then there are folks who've just had advanced age, too many comorbidities that prevent them from having a major joint operation. This is a secondary option that is an injection, office-based. It could be done safely, quickly. Sometimes I utilize an ultrasound for precise accuracy, but it is another option for folks.
Great. Now, I'm assuming that epidurals are a big part of the intervention for the spinal pain patients. Can you explain what an epidural injection is, both in the neck and in the low back?
Sure. The epidural is actually a space. It's a potential space within our spine. It's a circumferential space that surrounds our spinal cord. And that space can be utilized to put medications. So most of us know someone who's delivered a baby who's had an epidural. In that case, they inject local anesthetics and pain medications to help ease the pain of a child delivery. For what I do is a little bit more specific. I put in a combination of anesthetics as well as steroids in a very specific location where the inflammation or the injury or the insult may be to allow patients to have pain relief.
Okay.
So it is a potential space that allows us access to the spine.
Can you show us on a model, like in the low back, where would the typical epidural go? And I'm assuming it's a very small catheter, correct? And people are asleep while you do this?
Most patients are sedated and uncomfortable. I do use local anesthetics to numb the skin surface, and this is a model of the lower spine, and most two common places that nerve injuries or pinched nerves or sciatica arise are in the cervical spine or in the lower back. Again, the epidural space can be approached from various means. The most common where what we call the interlaminar space, or meaning between the two vertebral bodies, we can access the epidural space from the midline space. However, when patients sometimes have had surgery in that space, scar tissue, post-surgical change prevents me from accessing that space safely. There are other approaches coming in from the side where we call a transforaminal, or through the foramen where the nerve root exits. And in some cases, I actually access the epidural space from the tailbone area where there's a caudal space that I can feed a small catheter up to where the problem is. And that could be done in the neck as well.
And what is the typical response for people? Do they feel immediate change? Is it several hours, several days later? What normally happens?
I generally tell patients that there is a bimodal or a double peak effect. Initially, they'll notice some relief from the local anesthetic or the numbing medication I inject. The steroids generally take about a week to 2 weeks to kick in. So it's a little bit more of a delay. Average pain response anywhere between 3 to 6 months. Some people last years.
Mm-hmm. And what is the reasoning for multiple epidurals? I know sometimes they'll come for a second or a third. What is the reasoning behind that?
There is occasions where I have to repeat an epidural. In the past, the dictum used to be, folks may hear series of 3. Mm-hmm. Our literature doesn't really show that there's any specific reasoning to do 3 per se. However, there is a additive effect of the steroids in a short period of time if you do more than 1 that allows the nerve root to have reduction of inflammation and reduction of pain. And there's a limit in terms of my practice how we limit the amount so that we keep our patients safe from having too much steroids.
Yeah, I think that's really important. Some people just assume, well, I need to have 3. And, and sometimes, or a lot of the times, they respond to just the first.
Correct.
And they do really well. And it's not necessarily to go to 2 or 3. But if they don't have a good response to the first one, are they always getting the second one? How do you kind of make that determination?
Well, in my practice, I always have the patients come in for a follow-up approximately 3 to 4 weeks after the injection. One, I want to make sure that they're doing okay. There are no post-procedural complications. And the question arises is if they're 100% better, why do a second? Mm-hmm. But if they're no better at all, then we'd have to ask some questions if we have the true correct diagnosis. Mm-hmm. And somewhere in between is where the patient and I decide together whether or not a second epidural is necessary.
Great.
And it depends on what the patient wants and what's the best treatment plan for them.
Good. The epidurals are obviously very common. Some of the other terms that people hear are nerve blocks. What is the difference between an epidural and a nerve block?
Well, an epidural is essentially a space where we put the medication in. The nerves originate from the spinal cord and originate in that area. So a general term would be an epidural steroid injection where it would bathe these nerves with the medication. Mm-hmm. But if I want to be more specific, say a patient has a very specific nerve root irritation where I only want to block that nerve, I would choose a different approach and block that nerve without blocking other nerves. Sometimes I do this for more diagnostic purposes or surgical workup where the surgeon wants to know whether or not that nerve is being pinched.
Okay, so you can get that specific. You can go right to one particular nerve.
Correct.
And block it, and that's a treatment approach as well as a diagnostic approach?
Yes.
Okay. And there's another term that we hear in pain management, radiofrequency ablation. What is that?
So essentially, using radiofrequency energy, we can generate heat. This is a low temperature heat, but by generating that heat, you can ablate specific nerves. For certain folks with arthritic type of pain that involves their facet joints or these specific joints in our spine, the formal term is zygapophyseal joint or Z joint, but generally known as a facet or a facet joint. Just like arthritis in the knee, you can have arthritis in your spine. Generally, the treatment for that is a course of aggressive physical therapy and anti-inflammatory medications. But if they continue to have pain, the joint being degenerated, there's not really much you can do about it, but we can actually block the nerves that innervate that joint. So by ablating the nerve or the medial branch nerve, patients would have pain relief. I would first do a diagnostic block by putting numbing medication around that nerve to block the nerve to see if they have pain relief. And if they do, we can follow that up with a radiofrequency ablation where the directed radiofrequency energy is used to generate heat to essentially ablate that nerve.
So you're talking really specific facet joint type pain for that.
Correct.
So is that, could you also do a facet joint injection there as a diagnostic? And then you would ablate or shut down the nerve with that
exactly.
procedure?
So
okay.
the term facet joint injection or medial branch nerve block, it can be used somewhat interchangeably. Okay. You can block the nerve or you can just inject medication right into that joint.
Mm-hmm. Yeah, I find that quite often as restrictions in the facet joint, and we work on that, and then sometimes the pain persists. When we come back, we're going to talk about some of the recent advances in pain management and some of the really dynamic techniques that are used to help people with chronic pain.
Hey, Mom.
Hi,
Did you
dear.
take your medicine?
Oh, gosh, I forgot it.
Her nurse,
You need a claim number?
her personal assistant,
Let me just grab a...
her housekeeper, her cook, her accountant. When I started taking care of Mom, I didn't realize the challenge of playing so many roles. But above all, I'm still her daughter.
Visit aarp.org/caregiving to connect with experts and other caregivers. Together, we can better care for ourselves and the ones we love.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today we're speaking about pain management, and our guest is Dr. Sean Lee. Dr. Lee, thanks again for joining us.
Thank you for having me.
When we left off, we were talking about some of the procedures that you use for chronic pain, and I wanted to ask you specifically, what are some of the statistics in regards to back pain, and how much back pain do you actually treat?
It's actually a very common problem. The incidence of spinal pain or back pain somewhere greater than 90%. So sometime during our individual lifetime, we have a injury that involves back pain. It costs our society lost wages, lost productivity, greater than $200-300 billion a year. It is the fifth most common reason why we see our primary care physician, and 30% of the time it evolves into a chronic pain problem. So it is a large entity, and I think now in the news is mainly driven by the currents in prescription opioid abuse. And to give sort of a little bit of magnitude of how bad the problem is, the United States accounts for 4.6, or just about 5% of the world's population. We consume over 80% of the world's opioids. So that is somewhat of a problem. And as you see folks and celebrities get into trouble with these medications if they're not used
What are some
properly.
of the common names of these medications in terms of the opioids?
In the news lately, Percocet, Vicodin, they all contain opioid-based medications along with acetaminophen or Tylenol. Not just the opioid has dangers attached to them, but the acetaminophen causes liver toxicity if used in excessive doses.
Good. We know that everybody does have back pain at some point in their life, and most of them respond to conservative care.
Correct.
That's the good news. Now, if they don't, what's available for people if they go through the route of they just have chronic pain, they're not responding to conservative care, the epidurals haven't been effective, surgery is questionable? What are some of the options out there? What are some of the recent advances that can help people block their pain?
So there's some real exciting things, innovations recently. One of the things that I'm passionate and I'm interested in is neuromodulation. So instead of injecting medications into the spine or using oral pain medications, we essentially try to use electrical signals to block the pain signals from reaching our brain. I try to tell my patients that's a form of a pacemaker for the spine. So using a very fine wire, we can actually place that in the epidural space and to send very targeted signals, programmable signals to address specific pain areas, whether it's the back, the lower legs, even the neck and upper extremities. And it's been quite successful, but it's not for everyone, but for folks who have had surgery and still have pain, or folks that just don't want surgery, or folks who are too sick and have too many comorbidities to have a major back operation.
I know in the past there used to be these implantable stimulators. Is the advance now going to you don't actually have to put the unit in anymore?
They're on their way.
Okay.
So far, I've brought a couple toys, show and tell tools that I use. So this is the typical stimulator wire, or lead as we call it. It's made out of a titanium material that has electrical contacts at the end, and this would sit somewhere in the epidural space. This is introduced through a needle. Patients get a trial which lasts anywhere from 5 to 7 days. So they're not committed to an operation or procedure without having a trial. So they get to see how it works first. This is introduced into the epidural space with a small needle. This is done under sedation. Recently, it's about 6 months ago, these wires have become MRI compatible, meaning that folks are not limited to CT scans and imaging modalities that require radiation. And if patients have pain relief from this trial, we would move on and implant the generator, the device. Essentially looks like a pacemaker battery. A lot of these companies are pacemaker companies to start off with, and the batteries are placed and implanted in the buttock area, completely under the skin. No one knows it's there but the patient. And some of these batteries have come a long way. 30 years ago, these batteries used to sit on a large cart. And now these batteries are no bigger than a peppermint patty, and they're smart. By smart meaning like your iPhone, where you turn it to the side and it knows it's sideways. Well, we're mobile and dynamic creatures. So when the patient sits down or lies flat, there's a accelerometer in these batteries that actually tells the patient that they're lying flat or standing up to adjust to their needs. And this is something that I'm very interested in and I'm passionate about. And again, it's not for everyone, but folks who've had other options exhausted, this is something that I can offer them. As you mentioned, other innovations in terms of things not being implanted. Can't tell you too much about it, but there are devices being developed where there's only a wire being implanted without having the battery implanted, where the generator's elsewhere, and that's in the works.
Cool. Well, that sounds exciting.
There's also a very specific implanted wire that I'm involved in a national trial on to move the science, where the wire is actually placed not in the spine but outside, next to the dorsal root ganglion where the nerve cell bodies lie. And if anyone is interested in that, they can always visit my website. We can get more information from the clinical studies division from that.
Great. Now, in terms of the impulse that's sent there, you said that this is electrical. Do people feel something? Is it an immediate turn off of the nerve, or what are some of the expectations? What's happening?
So the sensation that folks feel is a pleasant vibration or a buzzing or massage-like sensation. It's completely programmable. The intensity can be adjusted by the patient. The location could be adjusted by the patient. And the goal of it is, just like when we're young and we cut ourselves or injure ourselves, our mom would rub our hands to kind of ease the pain. This device, in theory, and this is a very crude way of describing it, it distracts our brain. Our brain is not sophisticated enough to feel pain and a buzzing sensation at the same time. So for feeling the buzzing sensation, it essentially blocks out the pain that's going into our brain, and patients get pain relief.
What are some of the examples that you would use this on? People with chronic leg pain from the spine? Can it be from trauma or injury? Are there some other indications that this would be effective?
I think you hit on all those points.
Okay.
Common uses, folks who've had back surgery who are not candidates for any further surgery, who can use this device for pain relief. Folks who don't want surgery, and then folks who've had injuries to their limbs. There's an entity called complex regional pain syndrome, which is acronymed as CRPS. It's a very devastating disease entity where this device has been shown to be very helpful.
That's exciting. Some people know that as RSD.
Correct. That's the previous term for it.
Kind of the old term for it.
Yeah.
But we still see patients that this occurs, and it's usually some kind of trauma, prolonged immobilization, they have swelling, just a lot of things going on. And they really have this chronic pain that hasn't been able to be addressed before. And this is something exciting that could do that. Huh?
Right. So not only this device, but the investigational devices that I'm part of trials is an accurate trial that's going on that specifically hones in on that dorsal root ganglion where that foot or that leg that may be having pain, we can actually hone in on that area and stimulate it to give people pain relief.
Now, if there's pain coming from multiple locations, can it cover a larger area, or you try to keep it localized? And then the second part is, you said the patient can adjust it. How much control do they actually have with it?
So these devices offer a large variability in terms of the number of leads I place to cover a larger area. Some companies offer larger amounts of contacts, or the electrical contacts. Some offer more than others. In terms of programmability, it can be made simple for certain patients who are elderly, as simple as an on-off button, to some of my younger patients and more of the iPhone generation patients. They can adjust the very minute program capabilities of these devices, and they're sophisticated beyond even sometimes when I try to program these things.
Cool. And how long will something like this last? Does the body accommodate to it? Does the battery need to be replaced? What is some of the times?
A lot of times, we're always at the mercy of the battery technology. These batteries are rated to last about 10 years. They are rechargeable, just like your electric toothbrush. Patients put a ring over their buttock area. It's nothing's, there's no skin broken. It's just something put over it to recharge. If need be, we can replace these batteries with a very small procedure.
Are there any risks associated with this? Is there a chance, obviously, of putting a foreign substance in a person's body? Can they reject it? Is there a risk of infection? What are some of the downsides?
As with, great question. As with any procedure, any intervention, there's always risks and side effects, which I have to go over with my patients. We do this under sterile conditions. We give patients prophylactic antibiotics. Risk of infection is very low. Obviously, you want to make sure that they've successfully passed through a trial so that this is going to work for them. In terms of possible side effects, these things are made of inert titanium and silastic silicone material, so the rejection is pretty uncommon. I've only heard case reports of folks who've had allergic reactions to these, which are almost unheard of. In terms of possibilities, possible other side effects, sometimes these leads can move or migrate, which can be revised. As you mentioned earlier, the batteries sometimes need to be replaced when they get exhausted over 10 years.
Mm-hmm. Now, we're talking a lot of times about the nerve being the source of pain. Are there options for people that have this level of pain that might not be coming from the nerve and some of the other structures?
Correct. Sometimes it's very hard to tease out, even specific nerves, or is this due to scar tissue? Is this due to structural degeneration of joints? When folks get beyond the point of where we can use something like this, there's also implantable pumps where we can actually deliver specific medications to their intrathecal space or their cerebral spinal fluid, essentially, and target that medication to the spinal cord. I also brought this as well. There's implantable pumps that are made available now. I generally use these pumps on patients with end-stage cancer, okay, who cannot tolerate high-dose opioids. So to avoid the systemic effects or the body effects to pain medications, whether it's nausea or constipation, we implant these devices which have a reservoir, and it's programmed to slowly infuse a medication directly into their spine or the intrathecal space through a very, very small silicone catheter. That can be done with a small procedure as well. These have been shown to be very effective in patients with end-stage cancer and folks with just complex pain that's not amenable to high-dose opioids or pain medications, injections, even stimulators. That has not worked.
Yeah, I think that's important. I mean, we think typically about the neck and back pain patient, but there's tons of other indications. As you said, cancer, I would assume people with burns or other serious medical problems that just need to control their pain.
Correct.
What would you say as the one thing going forward, maybe in the next 10 or 20 years, would be exciting in your field? What do you think is a possibility that's, that could be out there to help people with severe pain?
I think as pain becoming more visible in society as something that cripples our society, as well as the troubles of opioid addiction and abuse, I think there's going to be a move towards non-medical, non-injected. I think the premise and the focus should still be on preventative care. Mm-hmm. I think there's not enough emphasis on healthy living, on preventing injuries to the spine, on conservative therapy. I'm a big proponent of healthy living lifestyle where in terms of, I think, weight loss, obesity becoming a very big problem in terms of spine pain. So I think our focus needs to look at prevention, as well as moving forwards in terms of technology and innovation, and certainly moving away from some would say less effective modalities like opiate medications.
Great. Dr. Lee, thanks for joining us.
Thank you very much for having me.
You've been listening to You and Your Health. I'm your host, Dr. David Bertone. We spoke today with Dr. Sean Lee about the recent advances in pain management. Until next time, we'll see you on You and Your Health.